My name is Mary Siki, and I'm the Associate Research Coordinator for the AWS National Medical Student Committee. I'm joined today by Hannah Thomas, our Research Coordinator, and we're delighted to be here. Today represents the second installment of our new AWS Research Methods Workshop series. We kicked off this series in September with our Qualitative Methods Workshop, and we plan to continue the series on a bi-monthly or every other month basis. If you did miss the first workshop, not to worry, you can check out the recording on our AWS YouTube channel. We are very excited about this opportunity to come together and build our internal and external research capacity by learning from some of the best experts in the field along the way. Today, our workshop is focused on clinical trials methodology. We will begin with a lecture from Dr. Christina Roland. Dr. Roland is an assistant professor and vice chair for research in the Department of Surgical Oncology at the University of Texas MD Anderson Cancer Center. She specializes in sarcoma surgical oncology and primarily conducts research in that area as well. Dr. Roland authored the Journal of Surgical Oncology Clinical Trials Methodology paper that we sent out via email. So we are incredibly honored to have her here with us today. She will begin with a presentation and we will moderate a Q&A after. Please feel free to post questions in the chat or the Q&A box as we move along, and we will compile them for the end. Thank you so much, Dr. Roland, for being with us here today, and I'll hand over the reins to you.
Thank you so much. I really appreciate the opportunity to speak with you all today, and I'm going to start sharing my screen and making sure that looks okay. But that looks okay? Yeah, great. So again, thank you so much. It's really a privilege to participate in this AWS Research Methods Workshop. As I hope you see at the end of this, I'm really passionate about clinical trials, and I think it's something that surgeons definitely can be even more involved in than we are at this point in time. And it's really a fulfilling research career, and something that I've really just become involved in the last 6 or 7 years, but something that I think is critically important to our patients and really provides a lot of satisfaction. So let's get started. So I'm going to just start off with talking just a little bit about general clinical research and and I think, as it stands in 2020, like these are really the ways that, surgeons can incorporate clinical research into practice. When I was a resident and we were doing, I did extra research time, during my residency because I wanted to do a surgical oncology fellowship. You really had to do basic science research, right? That's what everybody did. And that was kind of the way it goes. And fortunately, over the last 15 to 20 years, it's really evolved where there's a lot of other research opportunities, including, database or clinical research, health services research, education research, global health, and then clinical trials, which is what I'm going to talk to you a little bit about today. So I'm just going to start off with this anecdote to kind of lead, where I'm going. So, since you're all aspiring women surgeons in the medical student group, at some point in your life, you will be a surgeon, and let's pretend that you are a trauma surgeon appointed the director of the SICU, and you're really the only person in your division with formal research training. And your boss asks you to promote sort of exemplary clinical research and quality improvement, right? And they'll give you a little bit of money for a research nurse, and then you're allowed to apply for grants and those kinds of things, right? And so, what do you do and sort of how do you move forward with this, and the common approach, and one that's, sort of certainly historically been employed and a necessary part of clinical research is really to say, okay, I'm going to create a really detailed database to mine for publications and grants and things. And that's certainly something that we do and has historically been used a lot, right? A more enlightened approach might be, I'm going to take my data and also join sort of a network group, and then we'll implement that database together. So it's not just my data, it's a lot of people's data. But the last most innovative approach is really to develop what's called a learning healthcare system. And that's where you try to learn from every patient and include them in comparative effectiveness research or clinical trials and things. And that's sort of the impetus behind this talk today. And so, I do database research. There's a lot of important things that we can learn from database research, but there's also some problems. And that's what I just want to sort of highlight today. And it sort of sets the stage of why we do still need clinical trials. So, databases can be prone to error. This is actually a study from MGH and Harvard where they looked at two different PIs. They took all of the patients and there was two versions of the database for the same patients. And essentially there was discrepancies in a huge percentage of these really important data fields, right? Things such as simple as date of birth, right? Which is something that's not an interpretable variable. That's something that's, finite and clearly defined. And in another recent study where they've looked at, 105 UK databases, about half the databases had produced 4 or few publications. And so these things can be a potential time sink and a source of frustration. And again, I'm not poo-pooing institutional databases. They are hypothesis generating, and they're sort of how we figure out our outcomes and what we're doing. But, really just trying to implore that we all only have a certain amount of hours in the day, and we really want to make sure that we get the most bang for our buck, right? And so if you are going to develop a database, really think about what the goals and the hypotheses are before you develop that database. Make the fields limited with a clear data dictionary so there's no confusion on what a variable means. Do routine quality checks that are predefined, and make sure that your goals are being met, and really time limit collections to specific hypotheses, right? So for example, if your question today is, what is the creatinine of a patient that's had a nephrectomy, that's fine. Collect the variables for the patients that you need, but then say at some point in time, you're going to stop collecting that, right? Because otherwise you end up collecting the creatinine on hundreds of patients that you'll never use it for. So why do we actually need clinical trials, right? We can capture all the data that we need in these institutional databases and learn everything that we need. And the reason is, so this is from one of my, when I got my master's, one of my mentors, Dr. John Tyson's a pediatrician, and he's absolutely brilliant and highlights this, that, we learn in medical school in particular, we need high quality evidence, and everything we do is on evidence-based medicine, right? EBM. But really, when we look at what we do every day in our clinical practice, about 80 to 90% of what we do is not supported by high quality evidence. Now, some of that's because they're not answerable questions. And that's kind of what we're going to go through today, is how to generate answerable questions. But a Cochrane review of some cardiology data, which is really the best, to be honest, they have a lot of the best clinical data on things, systematic reviews, which is our highest level of evidence, only about, in systematic reviews, only about 13.5% of that had high quality evidence supporting the treatment. So there is a huge opportunity, I like to think, of really improving the evidence that we use to make everyday decisions. This is the quality of evidence sort of pyramid, and sort of goes from the bottom, where expert opinion really has the lowest quality of evidence. And these are all the different kinds of clinical studies that you can do. Case reports are a little bit better than expert opinion. Case control studies and cohort studies sort of fall in the middle here. And this is really, our database studies sort of fall into this. And then things like standardized, randomized clinical trials, systematic reviews, and meta-analyses are really the highest level of evidence, right? And so again, not poo-pooing databases, but just highlighting that there are other ways that we can do things. And this is really the problem. And this was a paper published in the Journal of Clinical Oncology last year that I found fascinating. And essentially what these graphs show is they took, what the authors did was they took a bunch of randomized control trials, and it's funny, they have a typo here, they said trails, but it's trials, and looked for all of the observational studies that sort of were the background data for the clinical trial, right? And then they looked at the hazard ratios in the clinical trial and the hazard ratio in the observational study and plotted them against each other. Pretty easy to do. The blue line is the statistical line of best fit, right? So when Y equals X, which is what you would expect, that observational study should have the same hazard ratio as a randomized control trial. And what you can see is this is actually the line of best fit, which essentially shows there's essentially was no correlation between the hazard ratios generated in observational studies and randomized controlled trials, and further, when they looked at these matched pairs, In the gray is the RCT hazard ratio with the confidence interval. So some of them were pretty wide, and the red dots are when the hazard ratio in the observational studies were within the 95% confidence interval, and the blue was when they were out. And again, you can see it's sort of a hodgepodge, right? So these things have to work hand in hand. Observational data can generate our hypotheses, and then we have to figure out how to answer them in high quality studies. And these are just some examples. Again, this is from Dr. Tyson. Healthcare's elephants in the room, where we are convinced based on observational data that things are effective, and then we put them in a trial and it's not. And some of these things are pretty significant, right? Like the whole Vioxx scandal for pain, right? It was, we didn't find out until we put them in a standardized trial that this really had a lot of cardiovascular issues. We used to do carotid bypass surgery to prevent strokes, and then later found out that was a really bad idea. Lung volume reduction surgery for emphysema was something that was done in sort of the 80s and the 90s that was later proven to be ineffective, and so on and on and on and on, right? And our patients deserve for us to figure out whether or not these things are actually helpful, right? And so as mentioned, I'm a surgical oncologist, and so cancer patients are my passion. And this is just some data from the early 2000s showing, if we look at this is age on the x-axis, and this is a log scale of the number of patients participating in clinical trials. We're really good at putting children on clinical trials, and there's probably nothing anybody hates more than a kid with cancer, right? And so we're really good at trying to figure out how to make these kids live longer. But if you look here for adults, it's essentially 1% to 2% of adult cancer patients are on a clinical trial, right? And the last I checked, there's still a lot of patients that are suffering from cancer. So the impetus here is we need to really do better, and figure out how to include patients on trials. So the point of this talk, so after my little soapbox on why is this really important and why do I care so much, the next question is, how do I even begin to do this, right? A clinical trial seems like something that is so complicated, and it's so much easier sometimes to do a lot of these things. And so here I hope to give you just some information on how do I even do this. So when we really look at what's required for a good clinical trial, I think we can break it down sort of into these 4 things. You need the right question, and I'll actually spend the majority of the talk discussing that, because that's probably the most important thing out of all of these requirements. We'll need a budget, so we'll just talk a little bit about sort of the things that are required in order to, direct and indirect costs and things that you just need to think about when you're designing this trial. Personnel, sort of who you need to help you with this, and then monitoring. So the guiding principle for really all clinical research, but particularly clinical trials, is the clinical trial should be designed to answer one question, right? Keep it simple. That's what we always say. And that question should be carefully selected, clearly defined, and stated in advance. And these principles are very important for as you move through. We'll go through in just a minute some examples of some really important questions that are impossible to answer, right? And that's okay. We can sort of chip away at them one thing at a time. A clearly stated question encourages people to participate in your trial. Patients will be interested in participating in it, and it determines the credibility of the findings, whereas a poorly conceived question will destroy your trial, because the last thing you want to do is make this really complicated, expensive, and long clinical trial, and then at the end of it say we didn't really learn what we thought we didn't really answer what we wanted to. So it is important to think carefully about the meaning, structure, and intention of a research question prior to making any attempt to answer it. And I think that can apply to all clinical research, but particularly clinical trials. So clinical questions that are worthy of research meet these what are called the finer criteria. So feasible, can you afford to answer it, right? A lot of these things can be very, very costly, depending on if you want to use drug, how many patients you need to enroll, all of those things. And so feasibility is really something to consider. Is it interesting? Are your peers, surgical societies, are you going to be interested in it? You have to be the champion for trial more than anybody else. If you don't believe in it, nobody else will, for sure. And it will take much more time than what you think it should be. And so you have to find it interesting and convince other people to find it interesting if you want to push it through. is it novel? You know, is it something that will extend the knowledge of what we already know, or is it something that's known that you're just trying to answer a little bit differently? Is it ethical? You know, and clearly this ethics in clinical trials is not something I'm going to talk about today, but is clearly something that is extremely important, and something that we as a country and as a world have had issues with sort of in the past. I would like to think that we're moving away from some of those things, but you really have to think about, is it ethical? Would it meet the ethical standards of society to answer this? And is it relevant? You know, is it going to change practice in some way at the end of it? And so when you're trying to think about, is this question worth investing time and resources and patience in, try to think about whether or not these are part of this. As I mentioned, feasibility is something that is almost the most important thing, because again, aside from finishing a trial that doesn't answer the question, the other thing that you don't want to do is not be able to accrue to the trial or complete it because, you know, you thought that you had the resources, the interested collaborators, the funding to do it, and then to figure out afterwards that you're not. And these are just some of the things that are really critical. And time, I think, is something that we all don't have enough of, and so we have to really make sure with the time that we have, we allocate it appropriately. And it doesn't matter how interesting your question is if it's not feasible to answer it, you know. So how do you formulate a good clinical question into answerable research questions? So these are really some very fascinating but not answerable questions in their current format, right? What is the most effective treatment for retroperitoneal sarcoma? I would love to figure that out, but in the current format, that is not something that we can do. Which is better, antibiotics or surgery for appendicitis? A question that I think recently has been somewhat answered, but in this current format, this is not answerable. And is postoperative surveillance for pancreatic cancer rational? Again, a very interesting question. We spend a lot of time and money on post-op surveillance, but there's no way to answer this question. These are not specific, they're ambiguous. The scope is unclear. Which patients would you include? All these things need to be answered a little bit better. So this is a pretty standard format of generating an answerable question, and it's called the PICO format. And it's a way to really put your question into a structure that is answerable. And so it seems very simple. So P is population. Who are you going to include? And this would include your inclusion as well as your exclusion criteria. What is your intervention of or exposure diagnostic test? What's the comparison, right? So you have what your population, you know, and then what are you going to compare it to? And then what is your outcome of interest? And we'll go over outcome just a little bit, but there's a lot of things that can be included, and your outcome is critically important to figuring out whether or not you can answer your trial. And then sometimes people use a T, which is the time over which the study will take place. And if you including all of these components in your question ensures that it's clearly defined and specified, and it's easier to bring this construct to your study framework when you're generating your clinical protocol. So the population is the first part of this, of course. This is where you generate your inclusion and your exclusion criteria. They should be unambiguous. It should be very clear to anybody reading your protocol who you can include and who can you exclude, because in the end, even if you're the PI of the study, you are probably going to have someone else screening for your trial, right? You're not going to be, most of the time, the one screening all of these patients. And so you need it to be very clear so that someone besides yourself can know who to exclude or exclude. And particularly if you do a multi-center study where you send it to a different institution, those people need to be able to say, okay, this patient would fit criteria and this patient would not. And this again goes into feasibility. You know, the more exclusion criteria that you include, the more homogeneous your population will be. But again, you will then limit the number of people who are able to be included. And so then you have to look at your feasibility. You want to maximize your generalizability, because the flip of that is you don't want to say, you know, I'm going to look at patients 20 to 23 that have appendicitis with, you know, a 2-centimeter appendix with a phlegmon, but no abscess, right? That would be able to answer a very specific question. But the number of people that would be able to, that when that trial was finished, you would be able to say, well, if I have a 30-year-old with those findings, do these findings apply to them, right? And so, because in the end of all of this, you want to be able to take what you've learned and generalize it to the population, right? So You want participants who have the potential to benefit. You want participants who have a high likelihood of detecting your hypothesized effect, right? If you think your effect is only 10%, you have to have very clear differences in your group in order to be able to maximize that. You also want participants who are least likely to have adverse effects, right? The last thing you want is to have patients on your protocol that are having all these really bad things happen to them, right? That really looks bad for your protocol and is potential for having to stop. To minimize competing risks, you can't have too many protocols that have patients that would qualify for multiple things, because most of the time they can only be on one study at a time. And you want to make sure that participants are going to be able to adhere to your intervention. When we talk about outcome, there's a lot of different outcomes that we can include. Survival, at least for cancer studies, is probably the most common outcome. Either overall survival, recurrence-free survival, those kinds of things. There's more data coming out about biomarker studies. For example, change in T cells after therapy is a very common biomarker happening now. Quality of life indicators and patient-reported outcomes are something that are very, very important and are fortunately becoming more common as a primary outcome. Symptoms, functional, psychosocial outcomes, cost for things is something. And then RECIST, which is a radiologic measure of change in tumors, for example, is something in oncology that we use a lot. But the things to consider that are really important when you're trying to decide your primary outcome is you need something that's clinically meaningful, right? And although I do studies that have biomarkers, patients don't really care if they have a change in their T cell infiltrate, right? That makes, for the most part, no difference to a patient, right? And it may be that this is a precursor study to a bigger study, but you need to make sure that this is something that's clinically meaningful. Is it something that can be objectively measured? Things that are numeric and dichotomous variables, those kinds of things are much easier than things that are wishy-washy. And then what is the anticipated effect of the intervention on that outcome, and is that meaningful? Because all of these things will tie into the feasibility of your trial. So let's work through this. These are some questions this is a question that I went through, and I'm going to kind of work through putting it in PICO format. So again, I'm a sarcoma surgeon, so I'm interested. I would love to know what the most effective treatment for retroperitoneal sarcoma is. Again, but that's very ambiguous. We have no idea who we would actually include on this. So sort of the next step on this would be, does radiation impact retroperitoneal sarcoma? That's adding one kind of treatment, but still not clear enough. A little bit more refined is, does preoperative radiation reduce local recurrence? Here we've better defined what our outcome is, right? It's the outcome would be local recurrence. And the intervention we're probably looking at is preoperative radiation, but we're not really sure who the patients are or what the comparison group would be. Here I said, okay, fine. So we'll add in patients with primary retroperitoneal sarcoma. So that gives us some patients. Does preoperative radiation reduce local recurrence? So that's we have our P, and now we have our I, and we have a little bit of our O. But we're missing our C here. And so then here we can say, okay, I think this is a good PICO question. In patients with primary retroperitoneal sarcoma, does preoperative radiation followed by surgery reduce 5-year local recurrence compared to surgery alone, right? So that has our P is primary retroperitoneal sarcoma patients, our intervention is preoperative radiation, our comparison group is surgery alone, and our O, and actually T in this circumstance, is our outcome is local recurrence and the time is 5-year, right? So that's how you can kind of go from a very general question and keep sort of breaking it down into a question that can be, and this question was actually recently answered. So just an example of how you can take a really interesting question and kind of slowly break it down. So now I have my question. Now what do we do? So the next step is you need to generate your sample size, right? And so how many patients do we need to actually answer that question? And I am not a biostatistician. I will talk to you a little bit about error and power because they're important for figuring out sample size. So in order to figure out your sample size, you need to talk about what's called a type 1 and a type 2 error. So, and I'm assuming you've all had some sort of basic statistics class, because I know that was at least a little bit in medical school. It was not as much as I would have liked, but at least something. And so, your null hypothesis is saying that your intervention does not work, correct? And so a type 1 error occurs when you reject the null hypothesis when it's actually true, right? So your null hypothesis is that your intervention doesn't work, and a type 1 error would be when you reject the null hypothesis when it's true. And this is when we usually denote this as your alpha, which is normally like a p-value of 0.05, right? That's what's called an alpha, which is your type 1 error. A type 2 error occurs if you reject the null hypothesis when the alternative hypothesis is true, right? And that we denote as beta. And the power of a hypothesis test is the probability of rejecting the null hypothesis when the alternative hypothesis is true. And so we'll go into sample size because power is really 1 minus beta, okay? And so when you're generating your sample size, the things that your statistician will need from you is what is your level of significance that you're going to say is true? And so this we usually use as a two-sided alpha of 0.05, and that's for the most part, every study that you ever look at where they say we set significance as p-value equals is less than 0.05, right? That's what your alpha is. The power of your study is 1 minus beta, and this is usually set at 0.2. We're willing to accept a little bit of uncertainty for the power, but not so much for the alpha. And then the other thing that you need to know is your effect size with your standard deviation. I'm going to go through an example of this for you, but you have to know, like, okay, in the example that I provided, let's say the risk of local recurrence for retroperitoneal sarcoma is 70%. And I want to reduce that to 50%, then my effect size is going to be 20%, right? And so you have to have some educated guess, and it hopefully is based on some data that you've generated, most of the time from observational studies, but some educated guess on what you think the effect size is. Some pitfalls that happen all the time, and probably a lot of the reason that trials fail, is that you cannot work backwards, right? You can't say, okay, I only have so many patients, so and your alpha and your beta are pretty standard. So what happens is people change their effect size in order to make the numbers work, right? It's so tempting and it's so easy to do, but it rarely ever works because your study ends up being underpowered to be able to detect the difference that you want. And this is why you need a realistic treatment effect size. So this is just an example that one of my colleagues generated for our clinical trials course that we put on for our fellows, right? So he does a lot of pancreas surgery, so he's very interested in pancreas leak, right? So let's say you have figured out some magic way to reduce pancreas leaks, right? And so you want to prove it in a clinical trial. So if your baseline rate of pancreatic leak is 20%, if you want to drop and this is sort of the stated calculation, and you don't need to look at that, but it just sort of shows you how here you've set your alpha at 0.05 and your power at 0.8. If you want to, oh, sorry, I did these backwards. If you want to drop the rate, no, that's right. If you want to drop the rate to 18%, so just a 2% difference, you only need 76 patients per arm, right? A pretty small study. But if you drop the rate to 10%, so a 50% effect size, you now need almost 200 patients per arm, right? So you've gone up a lot. And if you want to drop the rate to 5%, then you need almost 6,000 patients per arm, right? Now, clinically, this is probably the most relevant, right? Dropping it to 5% because that's a 15% drop, but there's probably no way. This would literally take hundreds years and years and years in order to generate that many patients, right? So you need to have a realistic understanding of what your effect size is in order to be able to have an appropriate sample size calculation. And your statistician will harp on this because it's probably one of the most important things that they do. Okay, so now that we have our sample size and we have our question, we're going to move on to budget. And I found this quote the other day. I thought it was great. The dream is free, but the hustle is sold separately, right? You got to have some money as much as you want to be able to do this. Everything in this world, unfortunately, in some form or fashion revolves around money, and clinical trials is the same way. So I'm not going to go into generating a budget. Most institutions have people who are specifically hired to deal with budgets and the contract parts of these. For most of us, we have little to no interest in being contract people and those kinds of things. And so finding out who in your institution works with that is very important. in general, they are very interested in generating budgets and often will help you at the beginning to sort of get a general sense of what your study would cost, right? And it's really important because that goes back into the feasibility part of this, right? You may want to do a biopsy of a tumor, 3 times during their therapy, but then the budget person may say, okay, that's fine, but each time you do that, that's $3,000, right? So each patient is $12,000 for every one of these biopsies. You may say, okay, let's cut that down to 2 biopsies, right? So working through that before you get the study at the end, can help with sort of some of the give and take. So some of the components that go into the budget there's direct costs and there's indirect costs. And I always get these confused. And so I think it's important to highlight. So the direct costs are the things that you can directly tie to your study, right? Salary support, supplies like blood tubes or collection kits, or hiring the clinical studies coordinator that you need in order to do your screening. Patient care charges, some of those are covered by standard of care and sometimes they're not, right? And so these are things that would go under direct costs. Indirect costs are overhead. And as much as we don't like to talk about it, every institution has indirect costs and overhead, and it's the cost of doing business, right? You work for your institution and they love you and they support you, but they want some money for what you're doing, right? And so these are the things like the facility fee. These go into things like facilities maintenance and utility bills. It's kind of like your taxes, right? To pay for new equipment and those kinds of things. And they can be fairly significant depending on the institution. A lot of it depends also on grants, like different grants have different indirect charges, but it can be anywhere from 25 to 60% of what your direct costs are. So it's definitely something to talk to your budget person about before you get too far into this, because you don't want to get your study done and then realize that your budget's actually twice as much as what it was because your institution is going to ask you for a lot of indirect costs. Salary support is very important. They always harp on us for the principle for investigator, don't forget about yourself. Our knowledge is worth a lot of money and you don't want to just give it away, right? Most of the time, salary support that you get can go into, you can use that money to decrease the amount of clinical activity that you need to do, right? So you need, for any kind of research, you need either time or money, right? Time to do it yourself or money to pay for other people to do it. That's just sort of the way most of these things work. And so often if you get salary support for yourself, then your institution will decrease the amount of clinical effort in whatever way that they do that, RVUs, percentage, whatever it is. And so make sure when you're generating your budget, you really account for yourself in some of this effort. And also your research staff. A lot of places have, core research staff, but depending on the amount of time needed for your study, it can be that you need to use a lot of research staff support, and your department may say, you know what, we can give you a half of a person, but it sounds like you need a whole person and we don't have the budget for that, right? And these are people, right? And they make a decent amount of money. The other thing with this is when you have research staff, there's something called fringe, which is their benefits, right? So this is their base salary, but there's extra on top of that for their benefits and things, and that comes into your budget for your study. So this is not meant to scare you or terrify you or tell you that you can never do this, but just something that you need to think about when you're sort of trying to develop your trial. And then there's, of course, additional fees for everything that you want to do on your trial. The IRB that I'll talk about in a minute usually charges a fee for the cost to pay for the people that run the IRB, the investigational pharmacy, department administrative fees, pathology to cut slides, diagnostic imaging in order to have the radiologist read these images that are not being charged to insurance companies, intervention rate, all these things that sort of come in, and just things that we don't think about because on a day-to-day basis, we don't have to worry about any of this, but it's all things that we do have to pay attention to. So monitoring, so the institutional review board, or the IRB, is the administrative body that protects human subjects, right? This is your human subject protection training, and they are the ones that has to review your protocol and require modifications, say, no, this is not ethical, or no, this is not funded or not within the scope of what we're going to do. And you have to get IRB approval for this. Most IRBs actually are interested in having you do your studies. So even though it seems scary and terrifying, they do want to see more research come out. But it's their job to be fairly critical, and so it can be very intimidating. The IRB is what is done prior to actually doing your study. So this is before you actually start your study, you get IRB approval. Once you do that, then there's something called the Data Safety Monitoring Board, and this is on the back end of the study. And so what the DSMB does is any study that's a phase 2 or higher, which I'll talk about in just a second, is they will require you on a scheduled basis. Most of the time it's at least every year, but sometimes more frequently if it's something that is a little bit more dangerous. And you have to go through and present sort of the interim results of your trial, as well as any safety data and stuff like that. And so the DSMB can decide, you know what, you need to terminate your study early. If you're really lucky, it's because your intervention is so efficacious that the DSMB says it's unethical to keep going because your trial is so good that you need to stop it now and publish it and change practice. But they can also stop it early to say, you know what, this is too toxic and you can't continue. And they can also extend your trial. And so in the paper that the clinical trial that I sent, as I mentioned, when you're estimating your effect size, there's a lot of things that you have to sort of guess at the beginning, right? What's the survival rate going to be for this patient population? What is my effect size? If the original estimates are off, the DSMB may say, you know what, you thought you needed 400 patients to answer this, but I think if you get to 500, you'll really be able to answer your question. And they'll say, you know what, you need to extend your trial, and then you have to figure out how to do it. But that's usually a good thing because they're trying to make your trial better. So the last part of the talk, I just want to talk about the difference between pragmatic and efficacy trials, because I think this is an area where surgeons in particular can have a big impact. So this is just the classic picture of a randomized controlled trial, right? We have our population of interest. People get randomized to either an exposure or an unexposure, and then you figure out the number of patients that have an outcome and those that don't, and then you compare the groups, right? That's sort of the classic way that a randomized trial is done. These are the different phases of trials. So you can have a randomized trial in almost all of these phases. Phase 1 trials are really to evaluate safety. And here they talk about drugs, but it can also be for devices or new opioid medications or a lot of new surgical techniques. So phase 1 studies are usually very small, and really the goal of those is safety. Phase 2, which is actually the majority of clinical trials, are phase 2 studies. These are safety and dosing studies. They usually have 100 to 300 patients, and they're really looking at early efficacy. Phase 3 studies are the gold standard. Like now we take many hundreds to thousands of patients and really compare whatever your intervention is to the standard of care to try to find whether or not what you want to do is better than the current standard of care. And then phase 4 studies are things that are not done that often, but these are really post-approval studies. And they're actually really important because this is where drugs in particular are used more in the real world. There's a lot of side effects that are found in phase 4 studies that were not found in highly controlled phase 3 studies. So these are really important to do because they include thousands and thousands of patients and highlight things that maybe we didn't figure out in really the smaller study. So when we talk about clinical trials, the last things that we need to talk about are sort of internal versus external validity, okay? And internal validity is the extent of which the results that we see actually represent the truth, not due to methodologic issues like bias, right? So this internal validity means you did a very well designed clinical trial, and in the population that you had, the results are true. And the high internal validity really proves a strong evidence of a causal relationship, right? Cause and effect. external validity is if you take the observed results, how applicable are those to the real world, right? So in my appendicitis example, if you have a very small controlled population, it would have very good internal validity, but we don't know much about the external validity, right? Because it's such a controlled population that we don't know how to apply that to my patients. And so this is sort of gets into something called explanatory versus pragmatic trials. Okay. And explanatory trials are also called efficacy trials, which are what we actually traditionally think of for clinical trials. It's the ideal situation. There are studies that are done by experts with very homogeneous patient populations with narrow inclusion criteria. And in compliance and adherence are very strictly monitored, right? These are large drug trials where they want to know, is this one drug highly efficacious in this really small group of patients? Pragmatic or effectiveness trials are, how does this intervention work in real clinical practice, right? If we take all patients that were admitted for abdominal surgery and randomize them to a opioid sparing bundle versus standard care, what happens, right? In that trial, the inclusion criteria are very broad, right? Anybody that has abdominal surgery. Standard of care is a very kind of loosey-goosey term, but it is sort of the real world of what happens, right? Everybody sort of does their own thing. And so pragmatic trials have few to no exclusion criteria. Treatment is provided as routine care. It's the things that you do every day that you say, my partner does it this way, I do it this way, which way is better, right? And compliance and adherence are not monitored as strictly. And so when we look at this, for explanatory trials, it's does it work? And pragmatic is, does this work in normal practice? And this is just sort of a table to show sort of the differences amongst these two types of trials. I think, as I said, I think pragmatic trials are things that in general surgeons could do a lot more of. There are so many things in our everyday practice that we do, that I do different than my partner, because we both think that what we do is the right way to do it. There may or may not be a right way to do it, but we don't take the time to actually study it, right? And say, okay, which one of these ways is to do it? But there's very easy ways in pragmatic trials to do this. And so the last thing just to mention is, for all of these things, you really want to minimize bias, right? And these are just sort of the more common kinds of bias that we find in clinical research. Selection bias is where you only select people that you think are going to benefit in one group, but you don't in the other group. And so then the group that gets your treatment looks better only because you better selected the patients. The way to control that bias is by randomizing, or also blinding, which we didn't really talk about today, but blinding is a good way to do that. Uh, Again, observer bias you can do with blinding. Bias to the introduction by exclusions after randomization. So meaning, anytime you enroll a patient on a clinical trial, not everybody is going to end up getting all of the treatment that you wanted. And there's something called the intention to treat analysis, means you include everybody who got randomized no matter what the trial they got, and that helps you to eliminate this bias. And then publication bias is actually a huge problem in medicine, because we don't publish negative trials, right? It's very difficult to get negative studies or negative trials published. And another way to do this is that really all clinical trials should be registered on what's called clinicaltrials.gov, which is a government website where you can see all open and activating trials. And it really encourages, the publication of negative trials, because that's actually very important for us to learn from as well. So the last thing is just to talk about health related quality of life. This is something that hasn't historically been included in clinical trials as much as it needs to be. All of these things go into health related quality of life, physical, psychosocial, economical, psychological. And so these are things that we can measure now and are really important to include. So these are two books that I think are really great if you're interested in learning more. This Hulley book is available electronically in our library. So I imagine for many of you, it's probably available as well. And then this is a book that I think is just really great, that I took a lot of the concepts of what I sort of put into the talk today come from this book, and this is available on Amazon. So just two things if you are interested in learning more. So thank you very much. I hope that was helpful. And And, as you can see, I think that surgeons are underrepresented in clinical trials because it's not something that we learn as much about. I certainly didn't learn anything about it until really I almost got my certainly in my fellowship, my first faculty position. But we're really smart, and we're really good at answering questions. And so something that I hope you all be interested in participating in. So thank you so much. This is my contact information if you have any questions, and I'm happy to answer any questions.
Thank you so much, Dr. Roland. That was such a fantastic presentation. We do have a few questions from the chat. So I have from here, thank you, Dr. Roland, for this brilliant presentation. How do you think are systematic review more preferable for medical students in comparison with clinical trials? And that sort of ties in a little bit with my question of, how can these principles that you discussed be scaled down a little bit to create meaningful clinical trials or randomized prospective trials at an institutional or department level that medical students might be able to get involved with?
Yeah, that's a great question. So I think systematic reviews are always systematic reviews are fantastic. There are actually so many data that are out there that a bunch of small, even well done cohort studies. Dr. Tyson likes to show this slide where basically for like 15 years they kept doing these small studies of hyperbaric oxygen for babies, right? And when you actually put all the data together in a systematic review, it's evident that hyperbaric oxygen is like terrible for babies, right? But all of these studies kept saying that there was no difference because they were all too small. And so systematic reviews, I think, are a really fantastic way to generate evidence. And there's a lot of things where the good news is that most academic institutions, librarians are available and love helping do good literature searches. So it's good for everybody to learn how to do it, but they are time consuming and they're challenging. And I personally find like PubMed really hard to do like a good lit review, but these librarians are amazing, and you tell them kind of what your question is and they can do a really fantastic a systematic review for you to then you can figure out how to do a meta-analysis. So I think those are excellent ways for medical students to get involved, because also, as I said, you can work with librarians and other people who have a lot of expertise in this and sort of learn how to do it. There are good guidelines, and I can't remember what it is now, but through things like in JAMA, a lot of the times they have published guidelines on how to actually do a really good systematic review, and there's diagrams you have to use and flow sheets and stuff like that. And so there's a lot of guidance on how to do it well. The other way that medical students can get involved in clinical trials, and I honestly forgot about this until you just mentioned this. So I was actually involved in a clinical trial as a medical student. So I went to University of Miami, which has a really huge trauma. They have a huge trauma group, right? Because there's a lot of trauma in Miami. And I was involved in a clinical trial of bolus versus continuous tube feeds for patients in the trauma ICU. I have zero interest in trauma. I have a lot of respect for our trauma surgeons, but I don't like it at all. And I basically would collect all of the data sheets and help enter the data, right? And not that was was that the best use of like my brain? No, but it helped me to learn how, all the ins and outs of sort of how to participate in a clinical trial. I would sit there in some of the research meetings where they would talk about all of this and those kinds of things. So I think, and in general, as with the budget and things that I showed you, clinical trials are super expensive to run, right? But the best thing you can have on a clinical trial is like a really motivated medical student, because you're smart, you're motivated, you have like a timeline on when you want to get stuff done, right? And you're free in general, right? Like, let's be honest, I think that's another way of having that is very easy for medical students to get involved is actually participating in the data collection part of the trial. You're right. It's highly unlikely that today you're going to say, okay, I have this clinical question and I'm going to figure out how to do a clinical trial as a medical student, right? That's probably not how it is, but you can start sort of helping with trials that are ongoing and really start to get engaged to learn all of the ins and outs, because it is something that, as I said, it's highly rewarding, but it's really complicated, and every institution is a little bit different. And there's all these little nuances that you have to learn. So I think that's a really great way for medical students to get involved.
Great. Yeah, I think those are fantastic ways. And I know there are plenty of ongoing clinical trials at most major academic centers to get involved with. So Shannon wants to know, does developing a team / personnel for a study involve recruiting a biostatistician specifically, or do people usually do their own statistical analyses?
So usually for a clinical trial, at our institution particularly, I think for a lot of these, it requires a biostatistician. Now, the way, for example, for ours, where for when we do clinical trials, is there's a department of biostatistics, right? And those people are funded by the institution some way, and so often, and I think this is pretty consistent across institutions, is so for example, we have a biostatistician from the Department of Biostats that's like assigned to surgical oncology, right? And so they sort of help with the beginning of your trial, and then in the middle of your trial, they're not really doing so much, right? Because you're recruiting patients, they have to help you with your DSMB reviews and stuff, and do sort of the adverse event calculations and the effects and all those kinds of things. But usually it's something that they sort of are involved in the beginning, and then kind of at the end, and then not so much in the middle. It's very institution dependent. Some institutions will say you need to allocate X amount of dollars to help support the biostatistician for your study, right? And some will just say, this is a core resource that we provide as an institution because that's how we do it. And so, but usually you just go to your Department of Biostats to do that. As I said, for most clinical trials, I think unless you have an advanced degree in biostat, most clinical trials do require you to have an actual biostatistician to do the biostats for your trial. Yeah.
Mary, you're muted.
Thank you. Yes, I just realized that. So Kristen wants to know if you could speak a little bit as to how to randomize patients and who does that or knows how to do that.
So that's actually probably the easiest part of the whole thing. So there's before and I don't have any stock in this, but REDCap has like changed clinical trials. So REDCap actually has a function in it that can do randomization for you. So I personally don't know how to use it, but the people who make REDCap in my department know how to do it. And you can just put in how you want them randomized and sort of your criteria, and then REDCap will randomize them for you. That's probably in 2020 the easiest way to do it. The other ways that you can do it, and what people have done forever, is you create a different envelope with each different so you'll have let's say you have 200 patients for a trial, you'll have 200 envelopes, and you'll have an A and a B, and you put one little letter in each one, and then you literally randomly just pick the envelope. That's a pretty common way to do it. There are some randomization also, it's not something that I talked about, but randomization can get pretty complicated. You can do block randomization, you can do simple randomization, which is just 1 1 1 1 1 1. But usually there's programs where you can tell it in REDCap actually, you can do it. There's also programs online now where you can just you can just Google like randomization program, and there's ways that you can do it even just through the internet. So randomization now has actually gotten much easier than it was where you had to, before I said, do envelopes and stuff like that, where that's how people figured out how to do it.
Again with the muting. A follow-up to that is, do you have any experience or thoughts on clinical trials for rare diseases given the difficulty with adequate power?
I have a lot of thoughts on rare diseases because I treat sarcoma patients, which is probably one of the most rare diseases. There's only 13,000 patients in the United States every year diagnosed. So it is a very, very rare disease. I think clinical trials are almost not more important but well-designed clinical trials are extraordinarily important in rare diseases because you only have a very small number of patients that you can actually include on your trial. So as an example, I think there recently, fortunately, and I'll use sarcoma as an example, there have been some really good clinical trials in sarcoma that have been done so thoughtfully. So for example, immunotherapy is a new type of cancer treatment where, you know, you use your body's own immune system, you know, with medications to sort of activate it. And so immunotherapy has, you know, sort of taken the cancer world by storm, but sarcoma, of course, is late to the game because we don't have very many patients, right? And so the first trial in sarcoma that in immunotherapy, they were brilliant in the way that they did it, in that they said, okay, we know we're not going to be able to get hundreds of patients in all these different types, right? So there's 13,000 patients with sarcoma, but there's over 70 different subtypes, right? So once you start breaking that down, there's like very few patients to qualify, right? So what they did was they said, okay, we're going to say we can have 10 liposarcoma patients, 10 leiomyosarcoma patients, 10 alveolar soft part, right? And put caps on the number of patients and said, we'll use those first 10 patients and then we'll analyze them. And then in any one that we see a signal, then we will do a limited expansion into those groups, right? And so what ended up happening was there was 8 different histologies that they had. They did 10 in each of those groups. So it was only 80 patients. So a reasonable study to be able to do, right? 80 patients is not too costly. But you got 10 patients per group. And so, you know, if you didn't see an effect in 2, 3, or 4 patients, the likelihood of enrolling another 30, you're probably not going to see that much better, right? So if you don't get a response in a few, and then what they found was that 2 histologies had a pretty good signal that there was efficacy. And so then they could expand the trial in those 2 arms alone, right? And so I think the rare disease question is very interesting because it doesn't mean we can't do trials. We just have to think a little bit more outside of the box. You know, breast cancer is the poster child of cancer care and like of how you can, you know, use science and data to like improve outcomes, right? Breast cancer trials have like 4,000 patients per study, right? Which is incredible, but will never be done for rare diseases, right? And so in those studies, you can just take people and randomize them and you get, you know, lots of people. But for rare diseases, I think you have to just be a lot more creative on how you're going to design them so that in the end, you're going to get some answer to the question, right? It may not be that you get your definitive large double-blind randomized phase 3 trial, right? But that's okay. Whatever you learn from this well-designed trial is going to be better than no data at all, which is sort of the place that you end up in a lot of rare diseases, right? Is that we don't have any data because, well, we can't do a phase 3 randomized trial, so we're just not going to do it at all, right? And there's probably some intermediary that's better than nothing. So, yeah.
Thank you. We're going to take time for 2 more questions, which we have here. So Margaret says, first of all, she wanted to give some praise to you, that it's been outstanding. Thank you. I suspect I could fill in your outline/structure and have a study ready for IRB. But she had a question about, what do you mean, I think in terms of the budget, what do you mean by get no less than 1% paid effort? Does 1% paid effort mean that the PI gets 1% of the budget or only charges for 1% of her time?
Yes, that is an excellent question. So and I'll talk about pharma studies just for a minute because it makes a little bit more sense on that. So the NIH cap in 2020 for PI salary is around $185,000 or something, right? And so when you're designing your budget for your trial, you're going to have, you want to, you know, you're a good person and you want to like do good research and you're like, okay, I have a budget of $200,000, right? Well, I know I want to pay my clinical studies coordinator. They need to have a salary and I'm going to pay them half time, right? So you figure out how much that's going to cost. And then you say, you know, I really want to do, you know, sort of 2 biopsies of this thing and on my trial. And so each of those costs $2,500. So that's $5,000. So and then you say, okay, but my institution's going to take 25% of my budget for indirect costs. And so pretty quickly you realize, you're like, man, you know what? I would rather just give up my salary and use that money for, but that's the thing, is that 1% salary support on $180,000 is $1,800, right? And so the more salary support you take means that there's less money that you can use for your budget. So many times what people do is they just say, forget it, I just won't take any salary support, right? My institution doesn't require me to take salary support. I get paid what I get paid, right? But it's not, but you need to make sure that you account for your time in that, and take at least a little bit of budget to show that you're spending some time on it. So 1% paid effort means, yes, you're saying that part of your budget is going to be used to pay your salary, but each percent that you use is essentially money that comes out of somewhere else, right? And so the point of that is just make sure that you account for, and all of us are going to dedicate way more percent of our time than what we probably will ever put in a budget, because that's just how we are, and we work until the work is done, right? But you say, well, this study is going to take 10% or 15% of my time. In a low budgeted study, which is where you would use the NIH budget cap, that's like $20,000 just for your own cell. And you're like, no, I don't want to pay that, right? So that's what I mean, is just make sure that you account for some of your, sorry, the yard people, of course, like outside right now. Make sure that you account for some of your time in your budget, because it really is worth it. So, but you always end up spending more than what you've allocated in your budget on the study, because that's always what happens, right?
Thank you. And then this last question from Herman would like to know, what is your take on trials that look at both primary and secondary outcomes? Is this an overstretch, or can it be looked at from the view of economizing resources to answer more than one question in a single study?
Yes, so that's an excellent question. By definition, you should only ever have one primary endpoint. The primary endpoint is the thing that you have decided is the most important question and the most answerable question, right? Because your study is entirely designed around that outcome, right? That's the effect size that your statistician is going to utilize to generate your sample size, your effects, all of those things. Secondary outcomes are very, very important. And most studies have some secondary outcome. I think incorporating patient-reported outcomes is something that are fantastic secondary outcomes. The problem with the secondary outcome, though, is by definition, it is hypothesis generating, right? The trial lives or dies by whether or not the primary outcome is met. And so that's also why it's very important to choose a primary outcome that you care about. It doesn't matter if in your secondary outcome you say, look, it worked 50% of the time though, even though, so secondary outcomes are very important, and almost always in trials they're included, and they're good. If your primary outcome is disease-free survival, then often you use overall survival and all these other things as secondary outcomes. But the trial, by definition, lives and dies by whether or not your primary endpoint is met. And so choose that one wisely, but also for sure incorporate things into your secondary outcome that you're also interested in, and maybe fuel for additional clinical trials. I mentioned the retroperitoneal, the preoperative radiation trial was a negative trial, but they did a subgroup analysis in just this one type of sarcoma, and it looks like that one may actually be significant, right? But you can't use those data to make strong conclusions. It's only hypothesis generated, and you can then make another trial based on that. So.
Fantastic. Again, thank you so much, Dr. Roland, for taking the time to speak with us today. And thank you for everyone for their active engagement with the Q&A. There was an excellent dive into clinical trials research. I do look forward to seeing the results of everyone's future trials, or see what who's been involved in what. So in the coming days after this session, we'll be sending out a takeaway document. Hannah and I have been compiling some key pearls of wisdom and advice from Dr. Roland, and we'll be putting these together into a bullet point review for you to consult at a later date. Hannah is going to post a feedback form right now in the chat, so we'd appreciate if you take that so that we could improve upon this. Hard to improve upon this workshop, but we can make any adjustments according to your feedback for next time. We want to also take this time to let you know about our next workshop. Workshop 3 will take place on January 17th at 3 p.m. Eastern Time, and we'll focus on surveys with Dr. Karen Brazel, who's an expert in the field. Hannah will post the registration link now, so be sure to sign up for this as well. And there will be upcoming reminders on social media and email as well in the coming months. As I mentioned, we'll be taking the feedback you provide from this workshop and try to incorporating it into the next session to build and improve. So our central workshop will now conclude. However, about 50 of you, I'm not sure how many people will be coming, but hopefully will be coming to our follow-up breakout room discussion. And here we'll go through an exemplar clinical trials paper and discuss key strengths and weaknesses. If you would like to participate in these small group discussions in the future, please be sure to sign up early, as we will likely continue to assign this as a first come, first served. For those who were emailed for today, please exit this Zoom link and enter the one you were sent in your breakout room email. So again, thank you so much everyone for attending today. Looking forward to seeing you at our future workshops, and take care.